Good afternoon, everyone. My name is James Orvinsky. I'm the director of the Dahdaleh Institute for Global Health Research, and to my right is the associate director, soon to be the interim director, Mary Rutorowicz. And it's great to welcome you here for a wonderful end-of-year seminar. Our speaker today is a very significant and renowned epidemiologist who I'll tell you about in a moment. Could you pull up his slide, the opening slide? I'm just going to begin with, as we always do, with a land acknowledgement. And this is a hybrid event, so physical and online. And so land acknowledgements are about the physical land that you're on. It's not about a virtual concept of land, it's about actuality. And so for those who are online, I just urge you to think a little bit about the land that you actually are on. Here, we are on a traditional territory known as Takaranto, and now more commonly today known as Toronto. And we're here at York University campus in Toronto, or Takaranto. And I acknowledge very much its current treaty holders, who are the Mississaugas of the First Credit Nation, and also acknowledge that this is the traditional territory not only of the Mississaugas of the Credit First Nation, but of many Indigenous nations. And that includes the Anishinaabeg Nation, the Haudenosaunee Confederacy, and the Huron-Wendat, and of course the Métis. And this territory, Indigenous territory, is subject to what's called the Dish with One Spoon Wampum Belt Covenant. And this is an agreement to peaceably share and actually care for the Great Lakes region as a territory. And so with that acknowledgement, I'd like to introduce Ruwan. Ruwan, I'm going to bastardize your last name. I'm very sorry about that, but I'm going to give it my best shot.
Appreciate it.
Ratnayake, is that good? Ratnayake?
Yeah, that's perfect.
Like, is that a 99 or a 90?
It's a 91. It's a 91. There's still time. There's still time.
I've got a little bit of work to do. Okay. So Ruwan is a field epidemiologist and a modeler with considerable experience in humanitarian crises. He works with colleagues at the London School of Hygiene and Tropical Medicine to integrate modeling of communicable disease, acute malnutrition, and excess mortality with traditional field epidemiology methods. And this effort to integrate provides insights that can hopefully drive public health actions in crises around the world. Ruwan is also a fellow here at the Dahdaleh Institute, and I'm delighted that that has happened. He's a CIHR doctoral foreign scholar, and he completed a mid-career PhD in mathematical modeling at the London School of Hygiene and Tropical Medicine. And he did that in collaboration with Epicentre, or Epicenter, as we say, as we truly bastardize in English, but it's of Médecins Sans Frontières, or Epicenter, or the Epidemiology Center of Doctors Without Borders. And there he evaluated the effects of targeted interventions for cholera outbreaks using mathematical modeling and observational studies in the DRC, or the Democratic Republic of Congo. And before this, Ruwan was the senior epidemiologist for the International Rescue Committee, where he supported health programs primarily in the DRC, or again, the Congo, and in Chad, Myanmar, Sierra Leone, South Sudan, and for the Syria regional crisis. And he's also trained with the Canadian Field Epidemiology Program of PHAC, or the Public Health Agency of Canada, and he has published extensively both research and public health guidance, including articles recently in The Lancet, Infectious Disease, and guidelines for early warning surveillance systems in emergencies for the WHO. So Ruwan is a perfect example of a genuine scholar who also has the other foot genuinely in the real world. So he's what I would call the perfect example of a hybrid. Hybrid's academic practitioner scholar, and he is the next generation of hybrids, much like Imran. And I'm now the old and dying generation of hybrids. So I must say, Ruwan, I know your work pretty well, and your contemporary interest in cholera is something that genuinely interests me. And I made a lot of efforts actually over the last couple of years to engage with OCHA on a modeling exercise around appropriate cholera interventions, actually in the DRC. So I'm really looking forward to learning more about your work through your presentation. And don't feel obliged to focus on cholera in the DRC, but just so you're aware, I'm personally deeply interested in your work, and it's a real pleasure to welcome you to the Institute and to invite you to give this seminar. So with that, over to you.
Thanks so much. It's hard to follow up with that kind of intro, so I really appreciate it. I just want to make sure you can see my slides. Okay.
Mm-hmm.
Everything okay? Great. Okay. And display settings. Great. Okay, yes. Great. And I'm also a dad of 3 kids with a partner who's on call at the hospital right now. So I'm so sorry I couldn't be there with you, but someone has to pick them up. So I'm really delighted to be with you today to talk to you about a few things modeling related. I wanted to kind of focus on the fact that I am an epidemiologist. I'm going to be speaking from the perspective of a field epidemiologist who also sort of works on modeling as part of humanitarian response. But I'm not necessarily a modeler with a capital M. You know, I did a PhD in modeling, so I like that perspective because it helps me to introduce all of us to some ideas of how we can use modeling for purposes that we may not have imagined, as well as, of course, the challenges and pitfalls of doing so. Just to give you, some perspective on the different kinds of ways we've integrated, field response and modeling together. It's, as you can see from the pictures, we've done with different organizations as listed below, done quite a bit in terms of thinking through what true field investigation of outbreaks looks like and thinking about what more complex analytics might look like. And, a lot of my work also deals with reproductive health. It also deals with non-communicable disease control using novel methods and supporting teams to do that, supporting ministries of health to do that as well. So I think also for the people around the table, both figuratively and literally, the ones I can see it in York. I think your practical public health experience is critical to thinking through any sort of advanced statistical analysis. So I hope this inspires some ideas and creativity at your end. And yes, I won't be talking only about cholera, but starting broad and then zooming into cholera and DRC. So this is an outline of the seminar today. I'd love to keep time for questions as well, so I might rush through some parts of it. But first, I'm going to give a primer on epidemiology and humanitarian crises, and then talk about gaps and new horizons, what epidemiological modeling is and what it might offer. And then we'll go into a case study of cholera response in Eastern Democratic Republic of the Congo that was integrated modeling and field evaluation and lots of questions that came from both ends. And I'm trying to think through questions of decolonizing global health practice that run throughout any sort of intervention we do, any sort of research we do. So I would love for that sort of critical thinking to happen as well. So as I stated, we'll start with a quick primer on epidemiology and crises, just because it's such a good grounding for thinking through modeling questions that could be of practical public health importance. So you might have seen this time and time again. This is an explanation of some of the health effects of crises on human health. And we see on the top bar there direct health effects, so intentional injuries by combatants, injuries due to mechanical force, of nature during natural disasters, which is to say severe injuries that could cause mortality as well. We also put sexual and gender-based violence there as well as post-traumatic stress disorder and mental illness. So we think these are the direct health effects of conflict and disaster. But what is also really important are indirect health effects. So how do other endemic infectious diseases rise in the presence of conflict and the disruption it gives to healthcare systems and public health systems? What happens to non-infectious diseases in terms of continuity of care for your diabetes and so forth, and unintentional injuries that occur because of destruction of infrastructure and so forth. Also important are depression, domestic violence, child abuse. So this is to say this diagram isn't supposed to be exhaustive. It's not black or white, but it helps us categorize where preventable causes might be found. And because we're talking about complicated diagrams, here's an even more complicated one. So this is a conceptual framework of public health information in crises. So essentially what we're looking at here is, can we take these direct and indirect effects of crisis and expand it to a framework that helps us identify what trigger events are that give rise to risk factors that then impact on health outcomes, and then the ultimate impacts of crisis, which would be, as discussed, physical disability, mortality, and mental health problems related to trauma. So with any sort of modeling, with any sort of analysis, we're really trying to think through what are the risk factors, what are the outcomes, and often as epidemiologists, as you know, we're measuring outcomes and impacts. Most often outcomes, because they're sometimes a bit easier to get at than the impacts. So what I do want to impress upon you is that time and time again, we still see that excess mortality is driven by indirect and preventable causes of death. So in Congo and many other settings, nationwide household surveys done by my previous employer, the International Rescue Committee, has found that more than 90% of total excess deaths, so those are the deaths we wouldn't expect to see if there was no conflict, we would expect to see if there is conflict, are due to indirect and importantly preventable causes. So that relates to malnutrition, so we can prevent malnutrition, easily preventable childhood diseases, malaria, diarrhea, acute respiratory infection, so pneumonia and other related causes, and then neonatal and pregnancy related conditions. And this was true in Congo from 1998 to 2004 when these surveys were done repeatedly, and as continues on now. And this was true also in Sierra Leone 10 years after the conflict was declared ended. We were at IRC, we were still found moderately high mortality rates years after we supported scaled up community management of malaria, diarrhea, and pneumonia, targeting the main causes of death among children. But we're still seeing very high mortality rates that are just hard to reverse when the infrastructure is still not up to speed in terms of addressing preventable causes of illness. And we're talking about primary care, access to primary care at a geographical distance that is accessible, and high quality care that can result in reduction of mortality, even if children are infected with these diseases. So these causes are largely preventable, and we have to kind of figure out ways to address them, both from the infrastructure perspective, the access perspective, the behavioral and social norms perspective as well. So again, this is not a modeling question, but looking at the holistic picture of how we look at health systems in post-conflict areas to end conflict-affected areas to address these preventable causes. So now turning to epidemics and crisis-affected populations, they're also very important causes of morbidity. Sometimes they get more spotlight than endemic causes of disease as well. But nonetheless, this is something we are often, as epidemiologists, responding to, trying to forecast and trying to detect as quickly as possible. And we often see upticks of waterborne diseases, some severe and epidemic prone. And in the early 2000s, just giving you some examples over time that might help to situate the question. In eastern Sierra Leone, there was large-scale outbreaks of dysentery, serotype 1, a highly epidemic-prone disease that's coincident with very poor living conditions brought on by the ongoing conflict. And this can also be compared with 10 years or 20 years later, large outbreaks of cholera in conflict-affected Yemen that started in 2016 and really took hold in 2018 or so. And in both cases, it's represented by the kind of movement of this epidemic, of these epidemics are represented by delayed detection, by surveillance systems that are under functioning, incapable of detecting disease as quickly as we'd want. And that results in sort of a large wall of cases pretty early on, which could reflect actual infection and symptoms or late reporting of cases, then high attack rates, high mortality rates, as we see in the red graph on the bottom, and then a need for large-scale intervention because these outbreaks have become so large. So large clinical WASH, community-based intervention, which is just done at a very large scale. So essentially, what we've tried to do over the years as a community is institutionalize the early detection of outbreaks and crises. And this might be an acronym familiar to you, kind of unfortunately named because it has war in the title, but here we are. Early warning, alert, and response systems. So they're simple surveillance systems which take account of the disruption of routine surveillance in conflict and disaster affected settings, but also trying to take advantage of the infrastructure that's in place. So you have primary care facilities giving care to patients. So that is a place where disease can be detected, information can be gathered, but also we have displaced populations who are needing NGO supported care in new places. They're not covered by the national health system or the national surveillance system. So we need ways of supplementing that disrupted health facility surveillance, covering new populations. And really the major aim here is early detection and immediate notification of suspected outbreaks of just a small set of diseases that are really contextualized, locally relevant, and have the potential to transmit heavily across the population and then also cause severe morbidity and mortality. So apologies if this is something, I'm just getting you in the mood to talk about modeling, and this is the best way I know how, but these are kind of the bread and butter of public health in crises for communicable diseases, at least. So we traditionally think about what diseases should go under surveillance. And what I hope you can appreciate from these slides here is that it might look very different for different settings. So post earthquake affected areas in Indonesia in 2006, we might pick a set of diseases that have local importance in terms of severity and transmissibility, and then we might grade them for to understand what the risk is of transmission, of impact as well. So you can see there dengue, acute respiratory infection, typhoid, dysentery, influenza, they all grade quite highly in this particular context due to the usual environmental, social, behavioral, biological factors that contribute to those diseases being important. But then on the right-hand side, we can see the same exercise done for the start of the Russian invasion of Ukraine in 2022. And that list looks a bit different. COVID was on the scene, other infectious diseases, diarrheal diseases, measles, given very low vaccination coverage, substandard vaccination coverage before the crisis, polio, and even cholera. So it looks different. We kind of have this risk assessment going that we want to prime to understand what the biggest risks are in a conflict and in a disaster setting. And that's going to be very contextual. So I'll round out this discussion of sort of public health topics in crises by looking at another tool in the epidemiologist toolbox, which is risk assessment. So essentially, we're often asked to kind of figure out what's going on, and we have sort of an epidemiology toolbox to use, measuring morbidity with, say, mortality with mortality surveys and surveillance, morbidities with the EWAR system that we just discussed, and other forms of community-based surveillance. And then we want to put that together into a risk assessment. And that risk assessment should essentially cover both communicable causes of morbidity as well as non-communicable ones, reproductive health, maternal and child health, mental health. It should also give us an idea of the populations affected, where they are, how big they are, and so forth. And ideally, this is kind of incredibly, you're sort of putting together qualitative, quantitative, um, estimated information and data, and just information on the crisis to get an idea of where we are in terms of current and future health forecasts for that population. So I would almost call this sort of like a qualitative approach to risk prediction. You're just trying to make the most information of what's available. So that's kind of a state of the art of where we are, some of the tools that we use. And I feel like that's useful for thinking through what some new horizons might be for epidemiological modeling and assorted sort of fancy stuff that is traditionally sitting in academia somewhere, but can be really brought over, I think. So let's think about different ways we can use the information that we have available. Um, so this is the kind of scenario that I want to point out to you, to highlight for you in terms of a new horizon. We have, as you can see, a lot of data being collected, and that can be collected from these communicable disease surveillance that we're doing, mortality data, information on the population. It can also be collected from instruments like the minimum indicator service provisions for reproductive health. So the package that's put on the ground to support reproductive health in emergencies. Um, it can be collected from non-communicable disease risk assessments as well. So we have more and more data that's collected, and we kind of describe it quantitatively, qualitatively. It serves a great purpose, but we could potentially do more with that data. And a first really good step that we don't talk about enough is developing those data pipelines and tools for routine, reliable analysis. So I'm sure you've been there before. You know, a one-time analysis is important and interesting, but what if we want to do that over and over again? What if we want to comment on access to non-communicable disease care in a population in Syria, and we want to kind of do that analysis over and over? Well, we could create data pipelines and tools to do routine, reliable analysis. And that often falls a little bit in terms in the epidemiologist domain, but also in the modeling domain as well, because we need that kind of trusted and safe and reliable pipeline to create these more fancy analyses. So there's another opportunity there as well to do better communication through visualization and mapping of data. And half of the epidemiologists, this isn't a real survey, but in my head, you know, most of the epidemiologists that I meet who are interested in kind of moving their practice towards better communication are doing that through better visualization and mapping of data, because they want to share that information with colleagues who need to kind of get a lot from a little bits of information much quicker. So that's also part of our kind of new horizon as well. That's done, as you can imagine, in programs like R and Python, but also it involves a lot of sort of knowing your audience, trying to understand what they need, and putting it in a sort of information product that makes sense to them, and that is timely and can be done easily. Um, as I said before, we have the potential to do much better risk assessment using that collected data, using visualization, making it palatable, and doing some prediction as well. And essentially what we want to do is use all the data collected, not just for the sake of collecting data, but for the sake of accountability, to continuously inform the humanitarian response through good information products, through being responsive to people who are asking. That includes stakeholders in the humanitarian response, UN level, NGO level, Ministry of Health, de facto authorities, as well as communities who we're working with on a continuous basis. So this is where modeling it also sort of is a product of all of these areas. If we get all of those other areas right, we might have a chance at doing good modeling. And what does that mean? Well, it could mean to explain what's going on for a certain outbreak, public health crisis. It could also be used to predict what might happen. And traditionally, um, we think of these scenarios where we have a little bit of data to kind of predict in the very short term epidemiological scenarios that might happen. So that could include really critical questions like how many people will be displaced. So right now we want to know how many people are displaced and where they are, but then how many people will be displaced in the future would be a great question that modeling could help with. A traditional one, which everyone knows quite a lot about, is will there be an outbreak? You know, through COVID, we've seen that there's just a lot more awareness about the use of modeling to estimate whether there's going to be an outbreak, how big it will be, what some of the dynamics might be. Another area that I'll tell you more about in the case study is will an intervention be effective? So essentially, modeling can be used in a sort of a more light touch way than testing something new in the field. It might be used to simulate whether a given intervention might be effective, simulate some parameters, and understand what the resources would be that are needed to go into that kind of that kind of novel intervention prior to scaling it up or even piloting it. And one thing it did remind me of is that we do this. This is a paper that sort of tried to integrate what we know about outbreak analysis, and this was before COVID started, but nonetheless in 2019, that kind of aimed to look at what we know about analyzing data that's important for outbreak response and developing some sort of data pipelines, data science for informing response to those emerging pathogens. So it is kind of analogous in a way. We want to do the same for humanitarian settings where the needs are similar to outbreaks in general, but perhaps more tricky, more thorny with worse data available and less data available and more chaos in general. And I think what's important to think about, what would be nice to take forward, is thinking about as we develop this new way of thinking around modeling for humanitarian settings, is there a way to build a globally capable network while building this analytical capacity? Because again, modeling, as we'll talk about, kind of sits within academia. And sits in the north in lots of ways for lots of reasons. But you know, as we're kind of developing these approaches, it would be responsible and useful to think about who's most affected by crises and develop that capacity and transfer that technology in ways to our colleagues working all over the world. So this is kind of the what slide. You know, what is epidemiological modeling, or at least how am I perceiving of it? I mean, a lot of people, there's a lot of text there. I think the best one is kind of I've highlighted in blue. It's kind of a simplified version of reality based on essential drivers, and you know, a lot of the modeling that we talk about is around outbreaks and what might happen in northern settings. Um, but it can be so much more than that, and it really can give us a good sort of either a finger in the wind sort of understanding of what might happen in a given scenario. It can tell us about resource allocation. It can tell us a lot. And the types, this isn't a presentation about the types of models, but I did want to kind of get into that as well, just to make the point that you know, you make choices. You make choices with any sort of research that you do about complexity versus simplicity, and what it might present to the users, the end users of your research, the people who are affected. And we make choices with modeling. So we can do, if we start from the bottom, we can say they're more tractable, there's less data needed, they're easier to explain. Um, modeling techniques like branching process models, compartmental models that are kind of easier to populate in a way, easier to map out, easier to do, and are less computationally expensive. And we go all the way up to individual-based models where you're essentially following people and trying to understand how they interact. And those just are more complex. There's more data needed to parameterize those models and kind of tell those little people what to do and so forth. But they have the advantage of being able to track behavioral changes at the individual level, social changes, and that might be important as well in for different questions that we might have, where you have a novel pathogen in a population. In a refugee camp, for example, and you have behavioral changes, logistical changes that affect individuals differently. So I think this is more kind of complex thinking, but also the simplest ways can also be are usually the most um, useful in lots of ways as well in terms of the timeline of modeling that we often do for crisis settings. So now I'll kind of think out loud about why modeling would help in a humanitarian crisis. It seems like quite a big lift, but we have to kind of think about the gaps where it might be of use. So essentially, in the points we have here, I should say the diagram we have on the right is the most obvious part. It can explain outbreaks, how they happen, explain, maybe predict outbreaks, and that's hard enough as it is. But I'll put you onto the left, the table on the left. So essentially, we have little data at the best of times, but also a need for public health situational analysis. And that for modeling would mean kind of short-term forecasts of what might happen. How many people are going to kind of move um, uh, from Idlib to somewhere else in Syria. What does the cholera outbreak look like in Cox's Bazar? What does it look like in the next week or maybe the next month? Longer term forecasts are just much more difficult to do, but short term forecasts could really help us plan in lots of ways. We could explain key drivers of health outcomes, some of which are preventable and some of which are not immediately, like climate change. We could estimate and project operational requirements, vaccine needs, bed capacity. We could simulate and study realistic interventions in dynamics settings as well. Um, and that can give us evidence for impact. It can also help us develop study designs for studies we might do in the field. And then, as I said, dynamic models of population estimation are an emerging area and really important for kind of understanding who is where. So as you can see, what I've tried to do is show how all of these are sort of interrelated and can lead to a good cross-pollination between these gaps that we find in humanitarian response and information needs. So this is just a smattering of some examples that I think are quite good, which again focus on both communicable diseases. This malaria anticipation project looks at predictive malaria early warning systems in South Sudan. They can look at interventions, they can look at population. On the bottom left is some work that we are doing also in Sudan to look at forecasting child acute malnutrition for to kind of provide situational awareness as well. So there's a lot of examples swimming out there, and it is a burgeoning field. But yeah, why wouldn't you want to do it as well? Why is it challenging? So often we just don't have data. We may have this kind of data. We have some sort of population estimates to use. We have some sort of surveillance or numerator information to use. We need disease parameters for those particular settings. So as we know about COVID, it behaved very differently in different settings. Cox's Bazar comes up as a common example of what we thought might happen and what did happen. And what we probably don't have is information about how people actually mix and what their susceptibility is for infection based on how they mix in a camp or in a rural displaced population. We don't ever really have information on changing behaviors, perspectives, and social norms. And that's where qualitative research really could help a lot. Quick, rapid surveys could help a lot as well, but it's quite challenging when we don't have that kind of information. And we don't have common practices. So we don't have, it's not within the field epidemiologist toolbox yet. It might be. We don't have a common language within the system to talk about modeling And I have to say, it's a rigorous process. I did a PhD in it. I still don't feel like I know much about it. But it's not necessarily an academic exercise, but it's done by academics on that kind of academic timeline with those academic products. So it does kind of beg that same question that we asked around field epidemiology many years ago, sort of who holds the knowledge, who's most likely to be trained, and so forth. And, what is the comparative advantage that people in northern settings have through these very developed systems that integrate, computer science and epidemiology and academic centers. That is just kind of starting now with groups like Africa CDC, CMAD University in Somalia, and others. So, who holds that knowledge, who's developing these research questions is really important for modeling as well. And just going more into decolonization across public health practice, just some questions that I think about a lot. We do a lot of our modeling sort of thought process through mapping collaboratively with colleagues. Here on the right, although it wasn't intentional to kind of decolonize practice, we're doing some qualitative mapping using I think it's called causal loop analysis with community health workers, with providers at the district level in Syria and Jordan, and with program officers at International Rescue Committee to really understand how non-communicable disease care is delivered. And that is sort of a network of risk factors for modeling that could be quite informative and really forces you to confront some key issues that you wouldn't have necessarily thought about through a research perspective when you're talking to the community who's been sort of receiving these programs for a very long time. So actual participation matters, who to ask matters, the diversity of the population really matters. It shouldn't be the professor at a university in Somalia. It should be people in the communities that have been receiving these interventions for a very long time as well. And building that modeling architecture between Southern countries and then with Southern countries is happening and just requires a lot more work. So that question of who asked the research question, well, that comes from these collaborations that we're trying to kind of get off the ground as well. This is a collaboration with CMAD University in Somalia around mortality estimation and mapping that we're trying to kind of use that lens of decolonization and asking good research questions and grounding it in foundational work that national authorities and NGOs and local NGOs are already doing in country. So this is some work with our colleagues at CMAD that we'd like to kind of examine through that lens. So I will spend just the next 10 minutes, or maybe even less, talking about a case study of how we did do modeling to support cholera response in Congo and Cameroon. But I'll focus more on how it kind of came about and how it is attempting to change practice and be somewhat useful. And just in the background, this was my PhD, so take it with a grain of salt. You ask someone who did a PhD to talk about their PhD, they won't stop. So I will try to stop doing so. So we're confronted with some questions about targeted rapid response for cholera outbreaks and emergencies. So really what we wanted to know is how do we do more with fewer resources? When an outbreak is detected in a setting of chronic insecurity and conflict, maybe it's detected a bit late, but what can we do while those outbreaks are still small to target a ring around those outbreaks and reduce community-wide transmission as quickly as possible before these become very, very large outbreaks. So this is an intervention that MSF was interested in that hadn't really been tried for cholera. Some work had been done in Haiti using wash interventions to do case area target intervention. And essentially what we're doing here is looking at a localized response, a very localized fast response using district level teams to fix a radius around a household in red and apply multiple interventions. So hygiene kits, clean water, and hygiene promotion, antibiotic chemoprophylaxis to cut transmission among those who are infected, and in this case, oral cholera vaccination, where we were able to do this with MSF, even though it's vaccines are quite scarce now. We were able to kind of do this as a test. So in designing a study, we thought about modeling as being a good way to kind of test out what we might be able to do. So what's important, and I try to kind of think about this, is who drove the questions. Like we wanted to do some public health situation analysis to kind of forecast what cholera might look like in certain territories of DRC. And that was asked by a district health office in Uvira in South Kivu, DRC, the Ministry of Health, and also MSF and Epicentre. We also wanted to kind of collaboratively simulate and study these realistic interventions in these and as evidence for impact before actually implementing in the field or doing studies to do so in the field. We're also looking at operational requirements and looking at ways to design good studies using mathematical modeling. So I will accelerate a little bit here. Essentially, we started by trying to figure out what that ring size should be. How, if we were going to do it in the field, what what is the kind of maximum number of households we should target, and what does a geographic ring look like? So we used data, already collected data from the Ministry of Health on rapid diagnostic tested cases to estimate the location and timing of those little clusters that happen all over before it becomes a big outbreak, and then estimate those spatiotemporal zones, those radii of risk. And what we came up with, these are the kind of statistics used, but that's for another talk. So what we came up with was a map of where clusters are detected all over the territory of Uvira, of this area in South Kivu. And the red areas show where clustering really persists over the years of the high risk areas where we can prevent cholera from happening. We also found that these clusters are detected pretty regularly, and using the statistical modeling instruments we had, they could be detected rather early in their progression while they were still small, to kind of preempt the large spikes that happen. So those are kind of modeling tools that could actually be integrated into the surveillance dashboard of a provincial Ministry of Health. Um, and just without spending too much time on it, I could share the paper. We found that if we look at this diagram of a ring radius, about 1,000-meter radius was the zone of very high risk of outbreaks happening around any new case that would occur. So we use that to give information to where we should be kind of targeting this case area targeted intervention, and also where preventative efforts should be targeted. So where we really need better access to safe water, where preventative vaccination can be implemented. So kind of using that modeling to map to actual disease control priorities of that district health office, and understanding sort of where the best bang for the buck might be in a way. And this was taken in a way to design a study of case area targeted intervention that MSF and Epicentre and the Ministry of Health carried out in Congo, in Eastern Congo, in conflict affected areas as well as Cameroon. But we had much more traction in Congo. And essentially, we wanted to ask the question of what would the potential impact of CAT would be on the containment of outbreaks in their earliest phase, so say the first 2 months or so. So we did a spatially explicit metapopulation model to kind of understand this question. And this is a little bit about the methods. I think what's important is understanding what we did with it. So this is kind of the map of that same territory you saw earlier, and we sort of divided it into hundreds of these little squares where we imagined implementing this intervention and understanding how that spreads to the other squares if we don't implement it. And if we do, what does that mean? So we integrated population estimation as well as looking at the cluster size that you saw earlier and how, if we implemented that, what would happen. So zooming ahead, that's your kind of a description of the model. But zooming ahead to kind of tangible results, we found that if we did use CAT with single dose vaccination, we did see a reduction to near zero in most of the modeling that we did of the outbreak within 60 days. And we also saw pretty good results if we didn't have vaccination. And that's that's the reality we find ourselves in now globally. There's not many vaccines on the table, with manufacturers not being present right now for vaccination, for to provide vaccine doses. So if we only relied on treating safe water at the household level, giving a good jerry can that children can't put their fingers into, doing good hygiene promotion and so forth, in a modeling framework, we found that if you look at the blue dots, in general, it would kind of drive down transmission to a level that's somewhat manageable for the wider response, and at least to keep clinical cases down, while perhaps mass interventions were put into place. So again, it shows on the bottom left, CATI without vaccination didn't really reduce the spatial propagation compared to other scenarios, but it kept cases down, and that would be useful in terms of what we're doing now. So there's two things that really stood out to me. First, it allowed me to finish my PhD, which I was very grateful to do. Then also, we really used some of this modeling to inform observational studies in DRC and Cameroon. We sort of moved to real world evaluation simultaneously to doing the modeling. And my colleague Flavio Finger had done the kind of primary model for this to kind of show that CATI could be potentially effective. But also what we were able to do is do a little bit of modeling using some of those very simple modeling processes to estimate the sample size that was needed to do a study in the field. So we figured out that we need at least 100 of these CATI interventions occurring all over. And we were able to do this, support MSF and the Ministry of Health to carry out almost 120 of these CATI rings all over Eastern Congo and Kasai Oriental as well. And it showed some preliminary results reflect some of the modeling results, and that small outbreaks were contained when CATI was applied rapidly. So that's sort of forthcoming work, but it really helped us to have that interaction between the modeling and the actual carrying out of the intervention in real time during an outbreak and during a crisis, as well as evaluating it using more traditional epidemiological methods. And one thing that I'm really happy about is that the Ministry of Health in Zambia, a neighboring country, did approach us to do it themselves, to say we want to do case area targeted intervention for our next very large outbreak. And so I was there a few weeks ago to kind of transfer that information to them about how they might do it using their particular contexts. These are the provincial teams that were going to kind of figure out how they were going to do it in each of their provinces. So it was a nice kind of coming together of ideas, very humbling experience as well. But I think it's a neat way to kind of bring data modeling and real world experience to bear. So I am going to end it
That's great.
there. Um,
Perfect.
just to say, we have lots of opportunities, and we have a need for collaboration and a need for discussion about how to do this. And I hope this has inspired some thinking around how we might go forward. Thanks.
That's fantastic, Ruwan. That was really, really helpful, and especially your initial focus on a primer, giving us some very basic concepts and approaches to epidemiology in complex humanitarian settings. And then also your focus on gaps, a little bit of thought around where some of the gaps might lie, and also some of the challenges, and then a very good, like a really good overview of modeling in humanitarian crises settings, the limitations, the basic requirements of modeling in that setting or in such settings, and so on. So really, it's really an outstanding presentation from my perspective. Do people have questions? If so, just raise your hand. Please keep your questions brief. We only have a few minutes. And if anyone is online who would like to ask a question, also please raise your electronic hand, and we'll do our best to accommodate. Go ahead, Mike.
Mike, oh, right. I wanted to know what sort of considerations go into humanitarian crisis, which are characterized by dynamic situation with things changing very quickly over short periods of time. What sort of consideration goes into capturing that reality into a model?
I think that's an excellent question, and it speaks to the, major challenge here, which is that things change quickly and you can't necessarily predict it. Population displacement being one of those things where you have an influx of population or an efflux, people leaving, and then your models don't really tell you much because they don't speak to the population that's actually affected. So I think the best way to put it is being pragmatic and saying, what can we do in the short term? So some of the most helpful models, I remember during Ebola in Sierra Leone, some of the most helpful models were done by I think CDC did a model to say millions of people are going to die, and it was good for advocacy, but it wasn't really good for short-term, not, foresight about what's going to happen. And I think the best thing that was done was a group at London School of Hygiene and Tropical Medicine just did short-term forecasts of 2 weeks. What's going to happen in the next 2 weeks? That's the only way we could be a little bit more sure of what might happen in a time period where things might be the same. I don't know. So I think shorter term always makes more sense. And then as much as you can get in terms of the key drivers of that, whatever phenomenon that you're looking at, is critically important. So access to care um, or rains that are happening right now. I mean, these are really critical and important, but you have to sort of choose the most important ones. So I hope that helps.
Okay, thank you. Imran?
Thank you so much, Ron, for that fantastic presentation. There's so much to put in there. I want to hear more about it, and I look forward to more opportunities to learn about your work. But the question that always comes up with modeling is validation. How do we know the modeling is showing us something true? And I was really excited to see the preliminary data from the DRC with the CAT interventions. I'm wondering, out of that preliminary data, what are you learning about the modeling? How are you integrating the findings of that validation work into your modeling?
That's a great question. I mean, I think that doing a model shouldn't be an excuse to not using data that's emerging, right? That you're getting. So I think some of the kind of a one way to think about it is, and they do this for emerging infectious diseases when you just don't know much about the pathogen. You're getting information coming in. At the start, you have a model and it's quite naive, and you have to teach it and train it on other data that's coming in as it comes, and that's where maybe other methods are validation, machine learning methods, and so forth get pretty interesting. But I think there is a responsibility there too to use data that's coming in, and there are frameworks for doing so. So at least case data, at least what we know about transmission and infection, at least what we know about the severity of the disease, about mortality would be good to update as we get information. And that can be done in statistical ways, like we can talk about Bayesian frameworks and so forth to inform the model. But I think, essentially what you're doing is you're trying to ask whether, hey, does this mirror reality? Does this mirror what we're seeing? And I think I tried to get through this without mentioning COVID, but COVID did really show a lot about the limits of what we can sort of forecast using naive models. But we learned a lot from information coming in. So I think integrating that information in makes a lot of sense. And one thing I'll raise that's really important is for my modeling, just as an example, what we realized in doing CATI for cholera outbreaks in the field is that people don't really like to use aqua tabs to clean water. They don't really always do that. I mean, I'm preaching to the choir here, but what does that mean for modeling? You assume that, there's this perfect absorption of your intervention. So what you could do is you could be realistic, knock down the effectiveness of that intervention, ask questions about how that intervention is working, and go back to your modeling and rerun it and do those things. And the same can be said about behavioral aspects as well. How do people behave? How are they going to want to um, uh, absorb those interventions? Are there other external factors that prevent people from using those interventions? So I think behavior is the next horizon, the next new horizon. Yeah.
Thank you, Ron.
Thank you. Michael DeSante online?
Yeah, thanks again, Ron. Amazing presentation. You were talking about with the caddies that you found a lot of clustering on communities with that were near rivers and kind of the seasonal reflection. And, my entire research group are flood modelers. So I was wondering about, what have you seen that works or doesn't work about integrating kind of other discipline types of modeling or data or information in general with this public health epidemiological modeling approach?
I mean, I might turn that question to the group because I feel like we're just learning how to do that. I'm come from a background of like participatory action research, mixed methods, qualitative and quantitative epi research, and I think understand even that common language piece is important. So modeling needs to kind of come up with a common language to talk about uncertainty, to talk about what it can do, what it can't do, and what it needs as well. So some of the qualitative research that we did during Ebola was incredibly helpful for informing infection prevention control measures, for instance. So in the same way with modeling, I think we need to kind of know what to ask from other disciplines as well. And as it comes to methodological cross-pollination as well, I feel like that's happening. But I'm lucky because I work with the Center for Mathematical Modeling, where there's people that come from all different disciplines and then try to figure out what different methods sort of add to the mix. I think the most important thing though is still finding the simplest way of answering the question. And so if we could kind of grind down those methods to reflect simple ways of answering very good, impactful public health questions, meaningful to a variety of actors, I think that would be a big advancement. So you might know how to do machine learning, I don't, but it might be good to know how does that practically answer some practical public health questions? What are the research areas that are needed to refine those methods further? And so forth. And I would say the same for field epidemiology methods in terms of translating what the modeling questions are within for those methods.
Awesome. Thank you so much.
I have a question for you. I have many questions, but I'll just choose this one in the interest of kind of illuminating a certain idea. You showed your CATI map, or your map of CATI blocks or districts for the DRC. When you look at that, there's a spread, if you will, over time, right, of cholera to different spatial regions that you then map as either hot or not. So you see the red kind of progressing. And then you talked about, and that obviously is over time, right? So it is an infectious disease. And then you talked about intervention and choosing your CATI boundary as the boundary for different types of intervention. So the question to you, Ruwan, is a question about clinical medicine versus public health. So an individual perspective versus a population perspective in terms of how you design an intervention. It seems to me, and I'd love your comment on this is a really perfect example of where there is very clearly, at one level, a distinction between a individual patient care focus and a population focus. And I would love your comment on this. I would suggest that if you're looking at the red band in the Kivu region that you presented, from a population perspective, population health perspective, you would focus your interventions around the periphery of the band.
Right.
And that you would do all of the four things that you talked about: antibiotics, water and sanitation, targeted monitoring or surveillance, and so on. But you would focus initially around the periphery, right, in order to, with the objective, to contain, to control, and to mitigate against the spread, the further spread. If you took an individual clinical orientation, you would go into the center of the hotspot and you would provide clinical care as your number one top priority. Now, obviously, in practice, we do both, right? We mix these to the extent that we can with resources. But we've had a number of seminars on clinical public health as a concept, right? And so I would very much like you to comment on what I've just said. Do you agree, disagree? Do you have any insights, nuances, whatever? Obviously, you speak from experience, so it would be lovely to hear from you.
I think it's a great question because we are constantly dealing with the question of equity. You didn't mention equity, but I think that's an important concept here as well. Yeah, and we're targeting intervention, so we're trying to save resources nominally, but we're also trying to prevent spread from happening so you don't see the big red blotch over the territory. But it is a question of equity in a micro level as well. When we do CATI, what do I do for that household over there that falls outside the perimeter, right? So I think it is something kept in mind all the time. These are not, I think, similar to Ebola ring vaccination as well. I saw that Sierra Leone has moved to vaccinating all health workers just recently, which is a huge deal. But I think the same questions were relevant here. You know, only some people get the intervention. But it's an open question as to whether that comes at the expense of other interventions being put in place. And I think what we've done in Zambia, for instance, I'll put the answer as a case study here. In Zambia, what we ended up doing was looking at the National Cholera Preparedness and Response Plan to see, okay, we have CATI, it's not a silver bullet. Where does it fit in to clinical case management? Where does it fit in to mass surveillance improvements that have to be done, and so forth? It is not a replacement for the other pieces, and it's not a replacement for preventative work that will protect people. So I think that becomes, so what we've done operationally, a more tangible answer, concrete answer is suggested that in those big red blotches, we need to reinforce preventative vaccination before there's any infection on the map at all. And then when infections do occur and they're detected, then we use this incredibly less equitable intervention to target. And if it gets overwhelmed, we move to case management and reinforcing that because the clinical side is important in terms of saving lives. So I guess I'll just end it by saying it's a dynamic conversation. And there are so little resources that you have to have that conversation. Yeah.
And I would suggest that just to go back to Michael's first question, it's a dynamic conversation that becomes even more roiling, even more hot, the more unstable the situation is, right? So when people are moving, health systems are collapsing, when people are fleeing and you have limited resources, limited public health resources, limited clinical resources, everything that Ruwan has very nicely described just becomes even more roiling and more intense. Ruwan, thank you so much for a great presentation.
Thanks for having me.
There's a bunch of questions online that we obviously won't have time to go through, but there's one that does ask if it's possible to get a copy of your presentation. If that's possible, you want to share it with me, I'm happy to make PDFs, or you can make a PDF and we can share it around. But really, really fantastic presentation. So thank you for that. And I'm really looking forward to you being here at the Institute and working largely with the Humanitarian Water Engineering Lab, I think. You will be very welcome. So thank you for that. And with that, this is the last seminar of the fall semester. And I just want to wish everybody a great break and a happy holiday, and wish everybody both happiness and good health for the new year. And Mary will be chairing or whatever the term is these days, supervising, teaching, I don't know what it is, but we'll be managing, there we go.
Yeah.
We'll be managing the seminars going forward. So with that, thank you everyone, and best wishes for the holidays.
Thanks again, everyone.
Thank you, Ruwan. That was just great.